Okay guys, Neuro 18 skeletal muscles, let's do a warm-up. First question, what infections are caused by group A streptococcus? Streptococcus pyogenes. There are different categories of disease. You have the proliferative or pyogenic category of infections such as pharyngitis, endocarditis, skin infections, and bacteremia. You also have the toxin-mediated disease including scarlet fever, necrotizing fasciitis, and toxic shock syndrome. Then the autoimmune-mediated disease, which include acute glomerulonephritis and rheumatic fever. Which gram-positive organism is associated with each of the following statements? The first one is a gram-positive organism that causes scalded skin syndrome. It's Staph aureus. The epidermolytic and exfoliative toxin of Staph aureus causes this. Gray-white membrane in the posterior pharynx of an unvaccinated child is Corynebacterium diphtheriae, causing diphtheria. Pharyngitis resulting in glomerulonephritis is group A strep or strep pyogenes. Most common cause of meningitis is strep pneumoniae. Most common cause of osteomyelitis is Staph aureus. Serious newborn infection, group B strep, listeria, and E. coli are the three that you need to know, but E. coli is gram-negative. Now let's move on to the lecture.
Hello everyone, and welcome to our Step 1 video on skeletal muscle. Do you even lift, bro? I didn't want to say anything, but I'm looking a little light. I did legs yesterday, glutes, hammies, quads, calves. Today I'm going to do bis, tris, pecs, traps, but no machines. I mean, I got to hear the weights clinking to know I'm getting swole. Here, I'll do a pec dance for you. You're welcome. All right, so today we're going to talk about muscles, and we'll start with the types of muscle fibers. So what are those different types of muscle fibers? So the types of muscle fibers include type 1 muscle and type 2 muscle. Type 1 muscle is called slow twitch muscle, and this tends to be the red, darker muscles. They're red because they have more mitochondria, and they also have a lot of myoglobin in them. Now they participate in a lot of oxidative phosphorylation. Now examples of great type 1 muscles would be the calf muscles like the soleus and the plantaris. Now your abdominal muscles also have a lot of a higher ratio of those type 1 muscle fibers. And these muscles are great at sustained contraction. So they can contract maybe not very hard, but they can do it for a long time. And then there's the type 2 muscle fibers, and these are the fast twitch. So these muscles are less red because they have less mitochondria, they have less myoglobin present. So these muscles are not very good at electron transport chain stuff, but great at anaerobic glycolysis. And so when you lift weights, anaerobic weightlifting, really hard stuff, that's going to hypertrophy these fast twitch muscles very quickly. So the classic example would be your pectoralis major muscle, your biceps. So those are your different muscle fibers in general. So now let's move on to a muscle conduction to contraction. So a myocyte is a muscle cell. They are long, kind of tubular cells that have the ability to contract. Now each myocyte is composed of myofibrils, and myofibrils are composed of repeating sections of sarcomeres. So the sarcomere is the most basic unit of a muscle. Now the two most important proteins of a sarcomere are myosin and actin. Myosin forms a thick filament, and actin forms a rather thin filament. Now, when you look under the microscope, you'll see these light and dark bands, and these are the myosin and actin overlapping each other. And the sarcomere has a very distinctive pattern that, of course, you need to know for step 1. So, take a look at your study guide, and let's label these different zones of the sarcomere. So here, number one is the end of the sarcomere, and it is called the Z-line. So this is the border of the sarcomere. Number 2 is the actin filament. Number 3 is the myosin filament. The myosin is anchored to the Z-line, and that's going to be by number 4, which is the structure called titin. So it's a very large protein. Number 5 is the center of the sarcomere. It is the middle of the sarcomere, so it is often referred to as the M line, M for middle. 6 is the area that's just thick filaments, which is the myosin filament. Now, as you can see, there are no actin filaments overlapping here. So this is referred to as the H band. So think of H as only having huge fibers, and so the H band there is just thick filaments. And as you have contraction of the sarcomere, that H band is going to get smaller. Number 7 is the entire thick filament, including portions that either overlap or don't overlap within the filaments. So that's going to be what's called the A band, and that's going to be a constant area. Then number 8 is the I band, where you have just thin filaments. So I is a very thin letter, and the I band is where you have just thin filaments. And that also would grow shorter with contraction of the sarcomere. Another way to differentiate the A and the I band is that the A looks dark, and dark has an A in it, and then the I band looks light, and light has an I in it as well. So you may have to recognize these lines and area on an actual sarcomere, be able to recognize the Z lines on the outside, the M line in the middle, and then the H zone, A band, and I bands. All right, so that's it for the sarcomere. Now let's talk about how nerve stimulates the muscle cell to contract in another Lewis notes. So what's taking place here? Well, this is going to be a very simplified version of the physiology. So an action potential travels down a nerve, and acetylcholine is released, which then binds to nicotinic receptors on the muscle. Now the muscle cell depolarizes down the T tubule. And the depolarization eventually gets to a dihydropyridine receptor. And you might recognize that term, dihydropyridine, because of the dihydropyridine calcium channel blockers that end in dipine, like nifedipine and amlodipine. Now these dihydropyridine receptors are mechanically coupled to a ryanodine receptor on the sarcoplasmic reticulum. So once that action potential hits the dihydropyridine receptor, it stimulates the ryanodine receptor, which causes the sarcoplasmic reticulum to release calcium. Now calcium is required at the sarcomere level for a muscle contraction. Now that calcium binds troponin C, which is attached to something called tropomyosin. Now tropomyosin acts to get in the way of myosin and actin. So in the absence of calcium, tropomyosin is just preventing the binding of myosin to actin, and no contraction can take place. Now after calcium binds to troponin C, a conformational change takes place in tropomyosin that then allows it to move out of the way. Then actin and myosin are able to interact with each other, resulting in muscle contraction. Now remember, you also have to have ATP on myosin, supplying energy for the myosin head to ratchet along that active filament. All right, we're back. Okay, so going back to what induced the calcium to come out of the sarcoplasmic reticulum, that was the ryanodine receptor. Now I want to focus on that for just a second because there's a specific drug that inhibits the opening of the ryanodine receptor, and that drug is dantrolene. Dantrolene is a drug that's used in the treatment of malignant hyperthermia. One way to get malignant hyperthermia is by the co-administration of inhaled anesthetics with succinylcholine as a paralyzing agent. And what's going on with malignant hyperthermia is excessive muscle contraction. And with excessive muscle contraction, there's going to be a lot of generation of heat. So if you stop the release of calcium from the sarcoplasmic reticulum, then the muscle can't contract anymore. And that's why dantrolene is helpful in that situation. It blocks the action of that ryanodine receptor. All right, so now let's talk about muscle spindles and control of reflex arcs. A little bit tricky here. There's another way to divide types of muscle fibers, and this leads us to a discussion on how we control muscle contraction. The two types are extrafusal muscle fibers and intrafusal muscle fibers. The extrafusal muscle fibers are the functional units of muscle. They're actually doing all the work, all the heavy lifting, so to speak. And we subdivide these into fast twitch and slow twitch, or white and red, which we already talked about before. Now, when an alpha motor neuron from the anterior horn of the spinal cord stimulates the extrafusal fibers, the muscle is going to contract. So far, so good, nothing too difficult. Then the second basic type of muscle fibers are the intrafusal muscle fibers, and they make up muscle spindles. So these aren't here to do any of the heavy lifting. The muscle spindles are proprioceptive fibers that are embedded within the muscle tissue to monitor the length of the muscle. Now, when a muscle stretches, these muscle spindles stretch as well, and that stimulates a 1A afferent. Now, remember, the spinal cord accepts afferents with an A, and then it emits efferents with an E. Or you might remember the efferents exit the cord, E for exit. But these 1A afferents coil around the muscle spindle, and they carry this proprioceptive sensory information from the muscle spindle to the cord and synapse on the alpha motor neuron, causing a reflex contraction. So when you stretch a muscle, the reflex arc causes that muscle to contract a little bit to resist that stretch. So if you tried to pick up a suitcase that's too heavy to lift initially, all that's happening is the muscle is going to stretch. And then that reflex contraction helps to counter that. So the signal is saying to that muscle, hey, this is extra heavy, you need to lift harder. Now there's another type of sensory organ in the tendon called the Golgi tendon organ, which monitors muscle tension rather than muscle length. Now, one way to remember this is to call it the Golgi tension organ instead of tendon organ. So the Golgi tendon organ sends a 1B afferent feedback signal to the dorsal horn of the spinal cord. They do the opposite of the 1A signal. They oppose the contraction of that muscle. So these 1B fibers stimulate a cell that sends an inhibitory signal to the alpha motor neuron. So when you lift that really heavy suitcase, they send a signal saying, hey, this is too heavy, maybe you should drop it. Then one other thing to be aware of is the gamma loop, which regulates the sensitivity of the muscle spindle. So this signal comes from the brain, and it stimulates a gamma motor neuron, which contracts the intrafusal fiber and increases the sensitivity of this overall reflex arc. So kind of tricky stuff there. So before we move on from muscles, let's cover some pharmacology, talk about some muscle relaxers or relaxants. So these are used for acute muscle spasm, like just a good old-fashioned back strain. We also use these for more chronic muscle problems. Think of things like multiple sclerosis. Baclofen is the first one here. It acts by activating GABA B receptors at the spinal cord level, and it induces skeletal muscle relaxation. Next, we have cyclobenzaprine. So it's a more centrally acting skeletal muscle relaxant. Kind of similar in structure to the TCAs. Also has some similar anticholinergic side effects like sedation and even dry mouth. Metaxalone is another muscle relaxant. We don't know the exact mechanism of action. It may work through kind of general CNS depression. Carisoprodol is another centrally acting muscle relaxant. This one's a little special. This drug is not a barbiturate, but it actually produces many of the same effects as barbiturates, and it's also a pretty addictive drug as well. It can potentiate the effect of narcotics, and therefore it's often abused in conjunction with narcotic use. In general, we're trying not to use this drug much anymore. All right, so now let's talk about some reflexes. I'm not going to spend much time talking about the reflexes we test clinically because they're pretty low yield, but it might be worth reviewing the nerve roots you're testing with all of these. So let's start at the bottom here. The Achilles reflex is going to test the S1 nerve root there. The patellar reflex is going to test the L4. The triceps reflex is going to test the C7. And then the biceps reflex is going to test the C5. And then while we're on the subject of reflexes, let's talk about the newborn reflexes or primitive reflexes. We use these to determine the health of a neonate's central nervous system. So first we have the rooting reflexes, where you stroke the side of the mouth or the cheek, and then it's going to cause the baby's head to kind of turn in the direction in search of food for the nipple. That's called rooting. Next, we have the sucking reflex, is when you place your finger on the roof of the baby's mouth and they start sucking the finger. So these reflexes, again, are going to ensure that the newborn will be able to nurse right away. The palmar reflex is where you just stroke the palm of the hand and then they kind of grab on reflexively. The plantar reflex, or probably more commonly referred to as the Babinski reflex, is where you stimulate the sole of the foot, and that causes the toes to fan out and the great toe to dorsiflex. And that goes away eventually, and if you stroke the sole of an adult's foot, the toes will actually plantar flex. But we check for this Babinski reflex in adults sometimes to assess upper motor neuron function. If you do this to an adult and the toes fan out, that suggests an upper motor neuron problem. And then we have the Gallant reflex, which is where you hold the baby on his or her stomach face down, and then you stroke along one side of the spine, and the baby will kind of flex laterally toward the side But my absolute favorite one is the Neuro reflex, where you lay the baby kind of flat on the table, you kind of lift them up by the arms just an inch or two, and then you kind of let them drop gently back to the exam. And the reflex kind of responds as they kind of abduct and extend the arms, and when they flex that, it's kind of interesting, like they're trying to give you a hug. It's like their response to falling is to reach out and grab a hold of something. Another way to test this is to hold the baby kind of like this, and then kind of drop the head down a little bit. You don't drop the baby on its head, but just lower the head quickly, and then you'll see that kind of arm go up as well. Parents don't like that one very much, though. Now, I've also linked some YouTube videos that demonstrate a lot of these reflexes as well. All right, guys, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, which two muscle receptors are responsible for opening the sarcoplasmic reticulum in response to depolarization? So we got to think about the dihydropyridine receptor and then the ryanodine receptor. Next, what drug prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscle? You got to think of dantrolene. Next, what are the differences between type 1 and type 2 muscle fibers? Remember, the type 1 muscle is called slow twitch muscle, and this tends to be your red, darker muscles because of more mitochondria and myoglobin. They participate in a lot of oxidative phosphorylation, and these muscles are great at sustained contraction. Type 2 muscle fibers are the fast twitch muscles. They are less red because they have less mitochondria and myoglobin. They do a lot of anaerobic glycolysis. Next, what are the differences between 1A afferent motor pathway and 1B afferent motor pathway? So the 1A afferent comes from the muscle spindle, stimulates the alpha motor neuron so that you get some muscle contraction. The 1B afferent comes from the Golgi tendon organ, and it eventually inhibits muscle contraction. And then we have a rapid fire fact: toe extension upon stimulating the sole of the foot with a blunt instrument. So that's going to be the positive Babinski reflex, or a positive Babinski sign. Often, to avoid confusion about what's positive and what's negative depending on the age of the patient, sometimes we'll just say that Babinski is downgoing, which would be normal for an adult, or we'd say Babinski is upgoing, which is abnormal for the adult. And you would need to say which side, like Babinski is upgoing on the left. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.